As many of you know, the Guttmacher Institute has just released a new report with the United Nations Population Fund. The title of that report is Adding It Up, the Costs and Benefits of Investing in Sexual and Reproductive Health Services 2014. The report, which was released in London just recently on December 4th, documents current levels of unmet need for modern contraception and basic maternal and newborn care, and the benefits of providing these services in terms of reducing maternal and newborn deaths and in mother-to-child transmission of HIV. In the webinar today, Jacqueline Darroch, an author of the report and a senior fellow at the Guttmacher Institute, and Sneha Barot, senior policy associate at the Guttmacher Institute, will be presenting some of the key findings from this report and their policy and programmatic implications. The webinar today is being co-hosted by PRB Center for Public Information on Population Research and the Guttmacher Institute, with funding from the Eunice Kennedy Shriver National Institute of Child Health and Human Development. And with that, I'm going to turn it over to Jacqueline.
Thank you, Mark, and hello, everybody. I'm here with Sneha Barot from the Guttmacher Institute to talk about our new report, Adding It Up, the Costs and Benefits of Investing in Sexual and Reproductive Health. These are estimates for 2014. For those of you who aren't familiar, the Guttmacher Institute is an independent, nonpartisan, and nonprofit organization, and we do work in an interrelated program of research, policy analysis, and public education, all directed towards the goal of promoting the highest standard of sexual and reproductive health for all people worldwide. The new Adding It Up report is the third in the Adding It Up series that we've done. It provides evidence showing why meeting women's needs for sexual and reproductive health services should rank high on the global agenda. The report covers all 149 developing countries in Latin America and the Caribbean, Africa, and all of Asia except for Japan, Australia, and New Zealand. The first report that we did for 2003 looked at contraceptive services. The second, with data for 2008, covered both contraceptive and maternal and newborn health services. Both of these reports became critical tools for policymakers and advocates, showing that these services are highly cost-effective and synergistic. The current report further expands the services covered. We have now added care for pregnant women living with HIV and treatment for curable sexually transmitted infections to our estimates. The estimates that we present rely on a wide range of data sources. The most important source is national surveys of women. We have data for 119 countries covering 98% of women of reproductive age in the developing regions. We also use data from organizations such as the World Health Organization and the United Nations, as well as a number of other sources for estimating costs and health benefits. So, what are some of the key findings? The most important is investing in sexual and reproductive health care saves lives and is cost effective. Substantial progress has been made in the past decade toward meeting women's sexual and reproductive health needs. However, large gaps still remain, and more progress is needed. These gaps are especially large among the poorest women and in the poorest countries. And finally, enormous benefits would result from investing more in sexual and reproductive health services. These include reductions in numbers of deaths, healthier women and newborns, and fewer unsafe abortions and unplanned births. These health benefits would in addition bring about many broad and long-term social and economic benefits for women, families, communities, and countries. So let's get into some of the numbers. We compare here data for 2003, 2008, 2014. The height of these bars shows the number of women wanting to avoid pregnancy in developing regions in each of these years. Women who want to avoid pregnancy are women who are sexually active, physically able to become pregnant, but say in surveys that they do not want to have a child within the next 2 years. You can see by the height of the bars and these numbers that the number of women wanting to avoid pregnancy rose steeply over the last decade, from 720 million in 2003 to 877 million in 2014. This growth of more than 150 million women who want to avoid pregnancy and therefore are in need of effective contraception was due mainly to population growth, but also to more women and couples wanting to reduce their family size and control the timing of the births that they have. You can see in the bottom part of the bars in the dark orange that the number of women using modern contraceptives also rose steeply, from 510 million in 2003 to 652 million in 2014, using women in developing regions using modern methods. At the same time, you can see that there's not very much change in the number of women with unmet need for modern contraception. The reason is that the increase in contraceptive use for modern methods was almost enough, but not quite, to keep up with population growth. What this tells us is that in the face of growing numbers of women in need, we need to not only increase contraceptive use to keep track with this growing numbers of women in need, but we need to increase the proportion who have modern methods available to them and using these methods to avoid pregnancy. Pregnancy-related care also increased. Here we have data for 2008 and 2014. But first of all, you can see that the numbers of births didn't change as much as the numbers of women needing modern contraception. 123 million births to women in developing regions in 2008, 125 million in 2014. And you can also see by looking at the orange parts of the bars that antenatal care increased and the proportion using the facility delivery for birth increased. So we're making progress in these areas as well. Still, we have 54 million women in developing regions who do not make this minimal recommended number of antenatal visits recommended by the World Health Organization, and 43 million women in developing countries who don't give birth in a facility. Now, averages can conceal large differences. What we see here is that the proportion of women wanting to avoid pregnancy who have an unmet need, are not using modern contraception, varies dramatically across the wealth of women within each region of the world. So, for instance, in sub-Saharan Africa, 73% of the poorest women are using no contraception even though they want to avoid unintended pregnancy, and 46% of those in the highest income households who want to avoid pregnancy have an unmet need. The gradient is less steep in Asia and in Latin America, but it is still a gradient that we need to help countries and women close these gaps so that there aren't these big differentials by poverty status. And we see that the same kind of difference by household income across the developing regions in terms here of delivery in a health facility, so that the chance that a woman giving birth delivers in a facility varies, again, dramatically, especially in Africa and Asia, outside of Eastern Asia and Oceania, by the woman's household income. In Africa, only 29% of women in the poorest fifth of the population deliver in a health facility compared to 82% of women in the wealthiest quintile. Let's look a little bit more at contraception. So first of all, we have 1.6 million women of reproductive age in developing countries around the world. Of these, 57% say that they do not want to have a child now. They are estimated to be sexually active and fecund, and therefore in need of modern contraception. 21% of women of reproductive age want to avoid a pregnancy and want to postpone a future birth. 36% want to stop childbearing overall. So 21, 36, they give us 57% of all women of reproductive age in developing regions want to avoid a pregnancy. It's 877 million women. What are they doing in terms of contraceptive use? 74% are using modern contraceptive methods, but 26%, at 225 million women, are not using modern contraception. What difference does this make? Well, one difference is that of these 877 million women who want to avoid pregnancy, is 26% using no method or a traditional method of contraception. They account for 81% of the unintended pregnancies in developing regions overall. And it's so dramatic difference because their risk of becoming pregnant is very high, and therefore they make up most of the unintended pregnancies. So in addition, what are some of the other indicators of unmet need? We have 225 million women wanting to avoid pregnancy, not using modern contraceptives. In addition, in 2014, we estimate 43 million women didn't deliver their babies in a health facility. 21 million didn't receive care they needed for pregnancy or delivery complications. Over 500,000 HIV-infected women don't receive medication to prevent transmission of HIV to their newborn. And 33 million newborns don't receive needed care for their complications. In addition, in developing regions, we estimate that 8 in 10 women who have a curable sexually transmitted infection received no medical care because they didn't recognize the symptoms. They didn't have symptoms that they connected with needing some kind of care, or they had symptoms and didn't get care. This is a large number of women. We're talking about roughly 160 million women in developing regions with a curable STI who don't get care. So now let's look at the costs and benefits of expanding and improving the services that are needed to meet women's unmet need for sexual and reproductive health services. The first column shows that first of all, contraceptive services currently cost an estimated $4.1 billion. Care for pregnancy and delivery care and care for newborns cost $9.9 billion for women with intended pregnancies, $4.3 billion for women with unintended pregnancies. So what we're seeing is an estimate of around $18 billion currently spent to provide the levels of sexual and reproductive health care that exist right now in developing countries. Well, what if we expanded the medical care to meet WHO basic standards? If we didn't change contraceptive care and only expanded maternal and newborn health care, we would have vastly increased costs. Unintended pregnancies, the cost for their care would go from $4.3 to $10.5 billion, and the total of maternal and newborn health care and the existing contraceptive care would be $40 billion. However, and this is the third column over here, if we expanded contraceptive care to meet all the needs for modern contraception in the developing region, we'd have to more than double the funds that are available to $9 billion. But the key thing is that we would be seeing a benefit in that economically, because that increase in contraceptive use would be preventing unintended pregnancies, and therefore for this, they would cost less to provide maternal and newborn health care for those unintended pregnancies, so that the total cost would not be $40.0 billion, but around $38 billion. When we put this together, we have an estimate that for every additional dollar invested in contraceptive services, there would be a savings of about $1.50 in the cost of providing pregnancy-related and newborn health care in developing regions. So let's look a little bit more at some of the measures that we have of impact on lives, health, and broader benefits. So if all the women, 225 million in developing countries who have an unmet need for modern contraception, use these methods, we can estimate that there would be 52 million fewer unintended pregnancies each year. What would that mean? It would mean 24 million fewer abortions, 15 million of which would have been unsafe. There would be 600,000 fewer stillbirths, 6 million fewer miscarriages, 21 million fewer unplanned births. And if both the existing needs for contraceptive and pregnancy-related health services were met, the number of women dying of maternal mortality each year would decrease from the current level of around 290,000 women in developing countries to 96,000 women in developing regions under a condition of expanded contraceptive and maternal care. A decrease of almost 200,000 deaths among women. And there would also be a decrease of over 2 million deaths from newborns if both contraceptive needs and maternal and newborn health needs were fully met. Plus, let's look here at women living with HIV who are pregnant. They need antiretroviral medication to prevent transmission of the infection from mother to child, as well as to protect their own health. Here we're looking at infant infections related to maternal child transmission. If no antiretrovirals were being used, we'd have almost 500,000 infants and newborns infected newly with HIV each year. At current levels, we have 273,000, 130,000 newborns, 143,000 infected through breastfeeding. But if all the pregnant women who are infected with HIV were able to have access to using antiretroviral medication, as recommended by the World Health Organization, we would decrease these infections through pregnancy and delivery and breastfeeding to 57,000, a decrease that is substantial and means not only saved lives eventually, but vastly different trajectories in terms of the health of those newborns and infants. What would it cost to provide the sexual and reproductive health services for all women and newborns in developing regions? We estimated a one-year figure, while some other organizations have estimated ramping up to some proportion of needs met. We're estimating here what would it cost to meet the needs in 2014. We saw earlier that current expenses are about 18 billion, or current costs are about 18 billion, and to meet all the needs, it'd be roughly a doubling of that for modern contraceptive care. You can see maternal and newborn health care is the bulk of the expenses. It's more than half of all the costs that we're talking about because those services are more expensive. Care for women with miscarriages and stillbirths, abortion-related care, And here we're making the estimate based on current conditions under which abortions are provided. So this includes cost of abortions in safe conditions and post-abortion care for those abortions that occur in unsafe conditions. Testing for HIV for all pregnant women and newborns, and then care for those pregnant women and newborns with HIV in up to shortly after birth, the first 6 weeks. And then finally, the care for women with the 4 major curable sexually transmitted diseases. Now, $39.2 billion is a large amount, but so are the numbers of women needing care and the numbers of women in developing countries. So that providing the women the care they need would cost, on average, annually $25 per woman of reproductive age in developing regions. That also works out to $7 per person in the developing world. About half of this cost, $13 per woman and about $3.50 per person, is accounted for currently by the cost of services at levels we have now. But we need roughly a doubling of these costs. It's also, though, this, when you think of $3.50 per person, it's relatively modest when you compare it to the current per capita health expenditures in developing regions, which is $270 per person. The enormous gains from fully meeting women's needs for these health services have to be weighed against the relatively modest increase in cost that's needed compared to current levels of healthcare expenditure. We expect that additional costs will be shared, as current costs are, by families, national governments, and foreign donor agencies and NGOs. So we're talking about care that is needed because women have a basic right for sexual and reproductive health care. We're talking about benefits that, in terms of fewer deaths, we can also show fewer years of disability. We're talking about cost-effective services when we compare the impact on maternal and newborn health care costs with the contraceptive costs. We're talking about needing more resources. But we're also talking about the cost estimates we've made are quite conservative, because we have not included what is known from other studies about broader and longer-term benefits that extend to women, to their families, as well as the broader society. For instance, benefits include increases to women's education and earnings, increases in household productivity, increases in GDP growth, and reductions in poverty. In fact, an analysis by leading economists commissioned by the Copenhagen Consensus Center placed sexual and reproductive health care among the top 13 most effective health interventions, in the top 13 of 169 health interventions that they evaluated. The evidence we present in the new Adding It Up is consistent with that report. So with this in mind, a take-home message that I'd like to leave with you is that investing in sexual and reproductive health care is not only something that we should do, but it's also a best buy in terms of health care. And with that, and I know you're chomping at the bit to ask questions, but with that, I'll turn the microphone over to my colleague, Sneha Barot.
Thank you, Jackie. So Jackie walked us through the findings of the report, and what my presentation will focus on is the policy implications and the opportunities of these findings. And what I'll be doing is speaking to the global level, but also the domestic level, since Guttmacher is a U.S.-based organization and much of our policy advocacy centered here in Washington, D.C. At the global level, The adding up findings have direct relevance to discussions happening at the UN on developing a new post-2015 development framework. The current framework, the Millennium Development Goals, or MDGs, they set forth a number of goals and targets to advance global development and reduce poverty. But since MDGs will be expiring in 2015, this year, early next year, policymakers, civil society, donors, and other stakeholders are very actively engaged in negotiations on what should be included in the post-2015 development framework. Advocates of sexual and reproductive health and rights are working hard to ensure that a target on sexual and reproductive health and rights is recognized in the new development agenda. And this is because the framework is going to very significantly influence funding, programmatic, and policy priorities among governments and donors for the next 15 years. So this advocacy is happening against the backdrop of another discussion taking place about the number of goals and targets that should be included in the new framework, since there's going to have to be a prioritization of these issues, and not all the issues will make it into the final list. An influential UN working group known as the Open Working Group recommended that 17 goals and 169 targets be considered for the post-2015 agenda. And among these, there were 2 targets that specifically focused on sexual and reproductive health services. The findings from the Adding It Up report provide strong evidence to show that the other global development objectives that the world is coalescing around, especially those related to reducing maternal and newborn deaths, reducing HIV, promoting gender equality, and reducing poverty and advancing economic growth, are much more efficiently achieved and done so much more cost effectively when you also invest in sexual and reproductive health services. And on this slide, I've listed the first 5 goals of the Open Working Group final outcome document, just to show that sexual and reproductive health services is very relevant and necessary for achievement of just these goals and beyond these goals as well. Jackie already said this, but there were a group of economists at the Copenhagen Consensus Center that did a cost-benefit analysis, and they found that sexual and reproductive health services were among the top ranking. So turning now to the domestic level, what do these findings mean for U.S. policy? The U.S. government is already a leading donor in 3 of the areas of sexual and reproductive health identified in this report, and that is contraception, maternal and newborn health, and HIV. Even though it's clear that the U.S. is a strong supporter, it does have significant policy restrictions in its overseas family planning and reproductive health program, including long-standing restrictions on funding for abortion services under the Helms Amendment, as well as other policy restrictions. The Obama administration itself has opposed and reversed some of these restrictions, the ones at least that are under executive control, such as lifting the global gag rule or the Mexico City policy and supporting funding to the United Nations Population Fund, UNFPA. The gag rule is a policy that is imposed by conservative U.S. administrations, which prohibits U.S. family planning funding for foreign non-governmental organizations that use non-U.S. funding to provide abortion services or information or even engage in advocacy around abortion. So even though the gag rule is now no longer in place, the administration has also gone beyond reversing some of these harmful policies that were previously implemented by taking the initiative to create other policy and programmatic efforts to advance sexual and reproductive health. So for example, the administration has launched a high-profile initiative to end preventable maternal and child deaths through setting ambitious goals in 24 focused countries by 2020. And it marked the 2-year anniversary of this initiative in June at an event called Acting on the Call. which is being led in partnership with the governments of India and Ethiopia, with UNICEF, with the Gates Foundation, and with other stakeholders. The Acting on the Call report verifies the findings from adding it up. It recognizes what we recognize, which is that maternal and newborn deaths are dramatically reduced when there is investment also in contraceptive services. And this relationship is actually delineated in the report, the Acting on the Call report in the 24 focus countries that it identifies. So stepping back from the administration for a moment and looking at another part of our government, starting in January, we're going to have a socially conservative U.S. Congress with a track record opposing many aspects of women's sexual and reproductive health and rights. Yet, at the same time, there is also a record of bipartisan support for issues of maternal and child health as well as HIV/AIDS. And adding it up provides the evidence base to show that progress on maternal and child health as well as HIV is accelerated by investments in family planning. So the task of the advocacy community is to convince policymakers that they cannot achieve the goals of PEPFAR and of reducing maternal and newborn deaths without also investing in the full spectrum of sexual and reproductive health. The report certainly calls for investments in all the areas of sexual and reproductive health analyzed in the study, but the reality is that donors and policymakers don't always intuitively understand the role of contraception and why investments in contraceptive services serve as the linchpin for many other gains in global health. As Jackie already noted, being able to plan one's pregnancy allows women and their newborns to stay healthier. So the case for combined investment makes sense in other ways too. Investing in any of the areas of sexual and reproductive health care identified in this report improves outcomes in the others. Sexually active women are exposed to multiple health risks from adolescence through their reproductive years, and failing to recognize that services should be interconnected parts of a continuum of care that support women throughout their sexual and reproductive lifespan means that opportunities for care will be missed. I also want to recognize that while the report quantifies the costs and benefits of investing in sexual and reproductive health services, it also notes that health and human rights are closely intertwined. Quality of health care delivered in an environment that respects privacy, dignity, freedom of meaningful choice, freedom from harm and discrimination are just as important as accessibility and availability of services. And on that note, one final point I'd like to make is on access. The report identifies 225 million women with an unmet need for contraception. That is, they don't want to become pregnant, but are not using modern contraception. This statistic is not just about logistical or geographic or physical access to contraceptive methods. Previous Guttmacher research has analyzed the reasons why many married women in developing countries who are fertile and do not want a child in the next 2 years are even at all, are not practicing contraception. And while their reasons vary across country and region, the most widespread reasons had less to do with barriers to access, as commonly viewed than with other concerns. So, for example, some of their top concerns had to do with side effects or health risks, whether they were real or perceived, women's perceived pregnancy risk due to infrequent sexual activity, or opposition from their partners or others. So such findings mean that not only do we need to expand access, but they also point to what I previously mentioned about improving the quality of services. So that means, for example, better information and counseling about method effectiveness and possible side effects, and providing a broad range of methods so that women can make informed choices. Over the long run, however, I think policymakers and donors wanting to reduce unmet need for contraception cannot focus on just access or quality improvements alone. They will need to revive investments in new contraceptive technologies that address women's needs and concerns, such as methods with fewer side effects, non-hormonal methods, those that can be used without partner permission or notification, those that are multi-purpose and can prevent both pregnancy and STIs, are methods that can be used paracoidally, meaning that they're used at the time of sex for those who perhaps engage in infrequent sexual activity. So the larger point here being that addressing women's sexual and reproductive health needs involves attention to both health and rights. And when we do give women the means to plan their births and to stay healthy, they are able to enjoy a broader range of social and economic rights, which are then reflected at the community and the national levels as well. So I'll turn it over to Mark now for the question and answer session.
Great. Thanks very much. We do have a couple of questions that came in, and again, if anybody wants to submit any questions, there's a control panel on the right-hand side of your screen, and you should feel free to type those in. So we have a question about how important is supporting reproductive health education in schools as a means of educating adolescent girls and boys about avoiding unwanted, unplanned pregnancies.
You know, one of the things that is clear when we talk about, as Sneha has done so well, about what it means to actually have choice in terms of the contraceptives you're using, is information, correct information that helps you understand what those choices are or what you should be asking for in a service setting. And that's needed before people are sexually active, as well as throughout their reproductive lives as their situations change and hopefully new methods become available. Schools are one environment for providing that information. They're not the only one, and we shouldn't put the burden or the responsibility solely on health education and within schools and comprehensive sex education. But it is an important vehicle because everybody needs to have this information about what affects their lives so much.
There's a question, what is the rural-urban divide in these numbers, or do you have those kind of data, since that would think that would have implications for how you would tackle some of these issues?
That's a very good question, and it's not something that we looked at specifically in this report. However, it's a topic that has been dealt with by in other research that we've done in others, because there are such differences typically between urban and rural environments where women and their families live. Typically what we see is that the poorest women tend to be rural women, and that the services tend to be less accessible within a rural environment, so that women who live in rural settings have higher levels of unmet need for family planning, contraception, but also for antenatal care and for delivery care. So it's an important issue. It's one that where data are generally consistent, saying that we need to, when we're talking about special attention, part of what's needed is the rural-urban differentials. It's not to forget the urban areas, especially large areas where we have very poor people living in urban areas. So it's not saying everything's fine, but it's often worse in a rural area.
Okay. What can be done to address the concerns about perceived side effects associated with contraceptive use? Or is that an issue?
You know, it's an issue, and it's one that we typically measure on the basis of asking women questions, but it's one that action, we need to be not only providing women and their partners and with accurate information, we need to be helping train providers so that they know what is accurate information. For instance, the World Health Organization has medical eligibility guidelines have been very helpful, and countries adopting them, and so that providers are trained to understand what methods are best for women who have special circumstances is important. The other thing, though, is that we need to continue research and development for methods that have fewer side effects that would bother some women or men if they're using them. You know, a side effect doesn't always mean that something is wrong or bad. It means that something about your body feels differently to you, and we need to help get methods that have less impact on people other than their contraceptive or hopefully their STI prevention impact.
Okay.
And I would add one more thing to what Jackie just said, which is that certain side effects have cultural implications. For example, breakthrough bleeding among women using certain hormonal methods there's certain cultural sensitivity to women who are menstruating, and there's some conflation happening there. So it would be important to also invest in technologies with fewer side effects regarding the ones that women are specifically most concerned about.
That's very good, and also it brings us back to the need for choices among methods, so that women, if they want a certain type of method, or if they try one method and then find it's not well suited for them, that they need to be able to have easy access without any kind of negative feedback from the provider that says, oh, we've got other options that you can use.
What is the source of these data? Are these primarily demographic and health survey data, and are there any gaps in the data that we currently have that would help shine a light on this issue?
Oh, that's a very good question. There are multiple sources that we use for this information. However, we can start the information about the need and unmet need comes primarily from surveys of women. Demographic and health survey system is the key one, but there are some other national surveys outside that system, as well as the mix, the multiple indicator cluster surveys. So that we're starting with what women say they need or what women say they get. We're looking to the World Health Organization's guidelines on what are the essential services that women should be getting during pregnancy and delivery, as well as newborns. I must say that some of the details of what is care is being received have to be estimated from international studies, and that is one of the especially weak areas, but it's one that we have benefited by work that others have done. And then we are using a variety of costing data sources ranging from what commodity payments are for contraception to estimates of program and systems or indirect costs. So it's a variety of data sources where we take them from the women themselves. Where that's not possible, we rely on international statistical agencies and other data sources.
Okay.
And so that there are needs to get better data along these lines. There's also a need for more ability to break down data to look at special populations. The question about rural-urban is exactly that kind. We don't have information on differentials, for instance, in cost or differentials in terms of impact of service care and those in rural and urban. Age, we have much more now on household income. that we can use, but there will never be enough data to answer all the questions. However, the information that is available is really very consistent and makes clear, again, the basic messages. You know, progress is there's a lot of need, but progress is being made. There remains unmet need that is especially concentrated among poorest women and their families and the poorest countries, and meeting those unmet needs can have a big impact for women, families, countries.
Someone just had a clarifying question. They wanted to know which sub-Saharan African countries were included in the analysis.
All the sub-Saharan African countries were included. So we used the United Nations Population Division geographical definition for developing countries, and this includes all countries in Africa, all countries in Latin America and the Caribbean, all countries in Asia except Japan, Australia, and New Zealand.
Okay. And I think this is our last question. What role do country governments play, or should they play, in meeting some of these goals?
Well, as the report outlines, country governments already are funding a substantial share of the costs of sexual and reproductive health services, and when we think about fully meeting all of those needs, they will continue to bear much of that burden. I think, you know, the issue of funding is very closely intertwined with the issue of political will and government commitment, and that's a really important issue that we need to see some more governments stepping up and making that commitment.
Okay. Well, with that, I want to thank our speakers today for taking the time to present this information. I encourage everyone to go to the Guttmacher Institute's website. If you haven't seen the report, you can. I assume you can download a copy from there.
Yeah, and there's actually a bunch of other materials besides just the report that you can access on our website, including a fact sheet. You can also look at the executive summary of the report if you don't want to read the full report. It's also available in other languages, including French and Spanish. And we have several infographics and social media materials that are available related to the report.
And not yet available, but being worked on almost as we speak, will be an extensive methodological report that goes beyond the summary that is in Adding It Up, that will include regional data and some measures by country as well. That will be up in another month or two.
Okay. Well, thanks again, Jacqueline and Sneha, for taking the time today. I also want to thank everyone who participated in today's webinar. If you have any additional questions that you think of, you can feel free to follow up with the presenters. I'm sure they'd be happy to talk with you. Thanks very much, everyone. That concludes today's webinar.
Thank you.
Thank you.
Thanks.